Right, so almost the crescendo, I would describe this as. We're now going to go through some cases to hopefully really bring together the bits that we've discussed throughout the day, and I guess describe our different approaches to patients in different clinical scenarios, bring out hopefully some key bits about how we can ensure that sedation, if it's going to be performed, is done as safely as possible. But also, I'd imagine, and knowing these two pretty well, we'll probably have some very different opinions on how we would conduct sedation with these different cases. You know, we don't have to just disagree for the sake of it, chaps, but let's just see how our approaches might be slightly different. So I'm going to start off then, and I'm going to give you a case to think about. So we're called to a 40-year-old male playing football who went over on his ankle. Bit of a studs-up tackle, sort of thing Rob might do. Right into the medial aspect of his lower leg. Now, you get called as a pre-hospital critical care team to the football pitch. He's suffered this injury and he's got an open fracture dislocation of the ankle. Now, you're 40 minutes away from your local emergency department. Unfortunately, Rob has run off crying down the football pitch whilst he's committed this horrendous injury and been sent off with his red card. So what I want to know, guys, is how would you approach this clinical situation, and is sedation something that you're going to be doing with this chap?
Well, Simon, I'm happy to pick that one up to start with. Why not? This is a pretty common scenario, isn't it? An isolated, fractured lower leg, and we come across this all the time. We don't want to make this too dull, do we? We're not going to run through a total top-to-toe assessment, but we are going to do that. But let's not discuss that. Let's talk about whether we're going to sedate this patient or not. So, I mean, from what you've described, it sounds like this patient is normally fit and well. He's in his 40s. He's running around a football field on a Saturday afternoon. But now he's got this open fracture dislocation of his ankle. So, I mean, for me, I'm going to be looking at that injury. I'm going to be determining the degree of angulation. I want to know if there's any critical skin. I want to know if there's any neurovascular impairment below the injury. Those sorts of things are what are going to tip me towards thinking about a sedation. I don't know about you.
Okay, so I'll give you a bit more information then. So it does look like quite a displaced dislocation. This isn't something that you can convince yourself is actually in joint and he's got, a couple of gammy looking ankles on a good day. This is totally out of joint, obviously open, and looks dusky.
Okay. So thank you. That's useful information. So he's definitely forcing my hand down the sedation route now. I mean, could I distract him while I pull it straight? I'm not convinced. A play therapist probably isn't the right thing to bring in right now. And I think with a open fracture of the ankle, I'm not really thinking about a regional block, and I don't think any analgesia alone is going to cut this. So for me, this guy needs a sedation. He needs a sedation for the procedure to pull the ankle in line so that we can then splint the injury intact in anatomical alignment, hopefully reperfuse the distal areas and give him a better chance of recovering with no morbidity.
Rob, what about yourself? At this point in the story, you haven't been red carded.
I'll come back to the scene of the crime. Is that what you're telling me? Nice. Well, I mean, you've got a patient here who has got a time critical limb injury. I think that's the first thing to press on here. This could potentially have a horrendous outcome if you don't manage it appropriately. I think that the interesting bit here is that I've certainly seen these, and you will have seen these done without sedation. And there are some options which people might potentially offer to you. So the combination of opiates, as in IV morphine and Entonox, I've certainly seen these done under that before. But I think if we're looking for the optimal approach to this, and if it was my ankle that was out, I think this is absolutely the thing I would want a procedural sedation for. And this is, essentially this is a patient who's going to have a reasonably good ASA grade just from what they're doing. And, I think that this is going to be a brief procedure. And so this is almost like the dictionary definition of what you should consider a sedation for, I think. And that is, like you say, it's to get everything back into alignment and prevent any of those complications that might do it. I mean, I think the interesting thing is, what do you do if you're 40 minutes away from hospital and you don't have the option of sedation? Any thoughts on that, boys?
No, I think that's a great question, and probably one for a non-sedation course.
Fair enough. I mean, so I guess I'm just thinking, as in, what do you do? Do you give a little bit of something and try and get it reduced? Do you call for help, or do you just get moving with it in position? And those are all questions that will depend on different factors on that day, aren't they? But I think that if we're talking about this from a pure sedation perspective, is this patient a candidate for it? 100%. Is it going to be the sort of patient that will benefit from it? 100%. This is a guy who has got a painful injury. It needs correcting in a timely manner, and that dusky foot is going to be thanking you afterwards after that horrendous tackle from me.
No, I know my answer was a bit tongue-in-cheek, but that is a really valid point, isn't it? Because it's often concentrated on the pain of the procedure of putting that joint back. But actually, there's a huge amount of analgesic benefit, isn't there, by getting the ankle back to its anatomical position. And is 40 minutes, if you haven't got the ability to sedate somebody other than with Entonox and with an opioid, is a 40-minute journey in with your ankle out actually any safer and better than a one-off few seconds of relocating that joint, putting it in a vacuum splint, and then giving some analgesia? But yeah, I guess that that is a discussion that could go on for a period of time. So in the interest of time, what agent are you going to be using with this, gentleman?
Well, I mean, I think Rob already described, didn't he? This is a really short and sweet procedure, potentially very painful for that brief moment that you're going to be manipulating the ankle. So for me, this is a ketamine all the way. This is exactly what ketamine was designed for. He's going to be in and out of the sedation nice and rapidly. He's going to be safe with his protected airway reflexes. He's going to keep breathing. Everything is going to be fine. This is sweet. You're going to leave the football ground looking like a hero. I'm ketamining it all day long.
Already referring to your patient as an it because you didn't check the name before you sedated them. What about you, Rob?
Yeah, I think ketamine is a really good shout in this case, and I think particularly pre-hospitally it would be my agent of choice. I think in hospital, I think propofol is just as good an option here. The rapid onset, rapid offset. Your patients wake up. It's in many places people will be more familiar with it, and that's what it comes down to a bit as well. It's the agent that you're familiar with, but I think both of those are excellent choices, and the patient in hospital will do really well with either of those. And like you say, it's a very brief procedure to get it back in and get it casted and then get it x-rayed again.
What are you using with your propofol, Rob? I assume some fentanyl.
So yeah, that would be a good choice. I mean, it depends on what they've had and the timeline leading up to it. So if they've just had some IV morphine with the crew minutes before arriving, then I think that's okay. Do you know what I mean? I think it depends on what they've had, but yeah, some fentanyl would be great. Rapid onset, rapid offset.
Yeah, no, I think I'd be happy with morphine in this circumstance because again, you're going to need that analgesia once the procedure's actually been performed, aren't you? So ongoing opioid cover is not a bad thing to have at all.
And I think also, whilst we're on that note, let's not forget just preloading with a bit of IV paracetamol or oral paracetamol. We can definitely set that up pre-hospital, so you guys don't have to worry about that in hospital.
Yeah, that's a good idea. Yeah, definitely. I think, obviously the evidence around that is that they're both as efficacious, but clearly if you're, wanting to keep them, fasted, do you want to go there? No, probably not. Yeah. IV would be a sensible option, I suspect, in this. One of the few indications for it there. All right, nice one, chaps. Well, I'll fire a little patient at you. So just wanting to make you sweat a little bit, boys, here. So you've got a 55-year-old male with a sudden onset of chest pain and palpitations 1 hour ago. Now, when you enter the cubicle or enter his home, whichever you choose, I don't mind which, he looks horrific. He's clammy, he's grey, he's got sweat pouring off him, and he's got a heart rate of 210. Now, just to make things a little bit more tasty, he's got a blood pressure around 65/40, and of course, it's VT on that ECG, isn't it? So, is this patient a patient you're going to sedate, or are you going to leave him ticking over at that, lads?
Well, I guess we're going to start off, Rob, aren't we? We're going to consider the new resuscitation guidelines, and we're going to consider whether or not this is an SVT with aberrancy, and then we're not going to have to sedate them at all. We're just going to put his legs up and get him to blow into a syringe. But I'm sadly anticipating what you've just described there isn't an SVT at all, is it?
Well, I don't see many SVTs that look like that, how I've described them, no.
Okay,
so I would presume
didn't
it's
get
a
out
VT.
that one, so, this is obviously a patient who is in extremis, and he absolutely has to have a procedure, as in a synchronized DC cardioversion, immediately. Because otherwise, we're going to have a patient who's got zero level of consciousness whatsoever because he's going to be in cardiac arrest. So the question isn't, does the procedure need to happen here and now? The question is, how on earth can we make this procedure as safe as possible if we're going to go on to sedate the patient? Because what we've described already is that there are some real risks here with sedation when it comes to hemodynamic stability. And we've pretty much, thanks very much, Rob, had a patient described who's as hemodynamically unstable as he possibly could be. So I guess a lot of the focus is going to be on how to make this as safe as you possibly can. So to me, I guess the two things that are running through my mind are the length of the sedation that we're going to have, because I want this to be as short as possible. I want to be worrying about this chap's physiological status for as shorter period as I possibly can, but also picking that agent that has the most hemodynamic stability. So I guess the two things that we've got there, propofol, really quick on and off, and ketamine, good hemodynamic stability, although can give you a bit of vasoconstriction on those coronary vessels and is going to last for a little bit longer. So I'm going to say that in this chap, I'm going to go for propofol, and we'll come back to me justifying my choice and how I'm going to do that in a second.
I'm just reminding myself never go to hospital with a VT when Dr. Lang's on. But so I mean, that's an interesting choice, Simon. I look forward to hearing your argument. I think it is a tricky case, though. I do very much accept that, and I think the ketamine is really interesting, isn't it? Because given my excitement over giving ketamine to the last case, I don't really want to seem like a one-trick pony. But
better get your Entonox out then.
Maybe some ibuprofen or something. But I don't know. It feels like the right agent here, doesn't it? But I definitely might have some concerns around the catecholamine surge that you can have with it. And we always talk about it being a very stable agent, but actually, when you've got someone who's critically hemodynamically unstable, it's actually a bit less predictable. So I'm maybe going to go a little bit left field here, and I'm going to say that maybe I'm not going to sedate this patient. And I'm wondering about your thoughts on just using a strong painkiller. So going in with some fentanyl and a short, sharp shock. Excuse the pun.
Oh,
go on, Rob. Give us your opinion. And I'm just preparing my notes for this duel.
Well, it's my opinion in terms of what I'd do.
Yeah,
that's the idea of this, Rob.
Well, I think that's interesting. So I think in hospital, this guy would get propofol. Okay, I think they'd get propofol, and again, it's due to the rapid onset, rapid offset, and I think the concerns that Simon's mentioned around ketamine, particularly for these patients that are, for want of a better word, clapped out, are probably quite just. But I totally agree that there will be different ways that this is played around the world and around the UK potentially as well. But I think that I would hope a relatively small dose of propofol, so just at the very bottom end of what you can do to get them into a plane of sedation that's reasonable, would hopefully not affect that blood pressure too much, and actually the procedure itself will correct that hopefully reasonably quickly afterwards as well. So I think the onset and plus the offset of it being very rapid are the two factors that I would like about propofol in this case. So I guess if we're talking about a discussion between propofol and ketamine, because I mean I totally get where you're coming from, Jimbo, but I mean, I think synchronized DC cardioversion is going to be painful, mate, and I think I would rather not remember it if at all possible, and there's a good chance this guy will still remember it. So yeah, I think I will err on the side of sedation. But if you were going to provide sedation to this patient, so with propofol or ketamine, Simon, what would your dosing strategy be for it, given that they're obviously at the very extremes of their physiological reserves here?
So this is a classic case where the dose is almost more important than the actual agent in my mind. And we've talked, haven't we, about sedation needing to involve analgesia, but just like James is going to forego some of the amnesia and his patient is probably going to remember what's happening here, I would forego the preemptive analgesia with IV opioid, and no, I'm not going to be giving IV paracetamol for this one. Because we know that that's going to be synergistic when it comes to precipitating hypotension. So opioids are out the window, and much like people will describe doing an RSI for somebody that's shocked with propofol in a safe way. I think it's, Baltimore Shock Trauma, certainly a few years ago, was describing doing an RSI with sort of 10% the dose of propofol that they would normally use in a hemodynamically well patient. This is probably one of those patients that no opioids, then will get 10 milligrams, so 1 mil of 1% propofol, a big flush and a long wait to watch that circulatory time come round in this shocked patient. And actually, in that sort of patient, you can see a huge response to really, really small doses of propofol and be massively surprised. This would definitely not be the patient, if they weighed 80 kilos, to go in with a 40 milligram bolus and then to watch to see what happens, because you can predict what's going to happen and it's going to be a disaster. So this is really low dosing of propofol, a good amount of time to watch its effect. And just as James is doing there, accepting the fact that you may not get full amnesia, but actually you have gone some way to giving them a sedation for what is a truly life-saving procedure.
Yeah, awesome. That makes total sense. So just thinking about sort of pre-hospital, James, in terms of ketamine, if you were going to give some procedural sedation using ketamine in this case, would you similarly come down on your dose? And what sort of milligrams per kilogram would you be looking to give someone who was this unwell?
Yeah, thanks, Rob. And actually, for full disclosure, my practice and my PGDs for working pre-hospital at the moment actually do have VT, actually do have ketamine for a sedation for cardioversion. So, just to appease any managers that are listening, I'm not going to ignore it completely, I promise. I think it's a really interesting question, and absolutely, these patients are going to be ones that you are going to be super cautious with. And I think almost rather than having milligrams per kilogram in my head, I'm thinking more of the sort of the dose I'm going to give. If we're thinking about an adult, a standard sedation dose would be kind of quoted at 0.5 milligrams per kilogram, wouldn't it? So, I would still work that out so that I had a threshold in my head for, what was normal. But, let's take a 100 kilogram adult for the sake of argument. That's 50 milligrams for a normal sedation. Realistically, in this patient, I would be looking at giving probably 20. So I give 20 milligrams, 2 mils of ketamine. And I would, same with Simon, I give it a big flush. I'd give it time to go around, time to work, because this patient's so cardiovascularly compromised. The only balance you've got is with ketamine, you don't want to be trickling in your subsequent doses too slowly, because then you end up kind of trying to chase your tail and you never quite get the patient to the right spot. That's going to be really difficult with this patient, to work out exactly how long to wait before you give your next 10 milligram, and that would be my boluses. I definitely wouldn't be going any more than 10 milligram boluses. So yeah, absolutely, I'm going to be very cautious with this patient.
The interesting thing with these guys, though, I think, is that it really catches up with them after you have delivered that DC cardioversion as well. So you'll have somebody that looks relatively awake, and you get these little glances like, you're not going to do this yet, are you? But in that really shocked patient, you then find that once you have performed that cardioversion, they then go really flat, and then people understand why you went and performed that shock light in what might be deemed their plane of sedation. So it's all, isn't it? This is all about balancing that risk versus benefit and looking at the whole picture. And I guess purposefully, Rob, you've given us a patient that is in absolute extremis. I guess the other things that we should mention, though, shouldn't we, is that we should really be looking out for those complications as well. So there's going to be a high chance with this chap that he's going to become hemodynamically even more unstable. So having medications there to deal with that. So if you believe it's going to be vasodilation that you're going to induce, then having something like metaraminol ready, or if you believe that it's going to be myocardial suppression, then maybe even some post-ROSC adrenaline drawn up with somebody that is peri-arrest in the first place might be a good way to go.
Yeah, I agree, Simon. And I'd also have all of my arrest meds out and talk about, prepping the team. I think having a discussion with them away from the patient about what to expect and the potential for cardiac arrest would definitely be appropriate here, wouldn't it? Yeah,
absolutely. Yeah, 100% agree. But in some ways, clearly they're going to be on the pads. They're going to be out ready for a shock straight away, aren't they, if they do arrest? So, just making sure that everyone's aware of what that plan's going to be is a great starting point, I think.
Okay, guys. Well, this has been a lot of fun, actually, and hopefully we've taken loads of learning from this. I certainly have. It's been fantastic. And thankfully, I think it's my turn to pose the question. So obviously, I'm going to take you guys pre-hospital, and I really want to pose a challenging case because so far we've had, fairly straightforward cases, in terms of the whole situation. But we're going to ramp things up a little bit here. So now we're outside. It's nighttime. We're at the side of a rural A road, and we're dealing with a rollover RTC. We've got a 50-year-old female driver who is well encased in this vehicle. She's trapped mechanically by all of the encasement from the intrusion into the driver's compartment. She's got pretty significant chest injuries from the steering wheel, which has been rammed up towards her. And she's also pinned by her legs. We think she's probably got a pelvic fracture and almost certainly at least one femur fracture, but it's pretty difficult to actually access her because of the degree of intrusion into the driver's compartment. So really, we need her out ASAP to give her a full assessment and get her managed appropriately. But actually right now, she's pinned in the vehicle. She's screaming her head off in agony. She's, as far as we can tell, GCS sort of 14, 15. What are we going to do with her? This lady is in a lot of pain.
So what you've painted so far, in my mind, I guess, is somebody that is obviously got a huge likelihood of being critically unwell and critically injured. And we need to make a full assessment, but we can't really do that to completeness in the position that we're in at the moment. And I guess this is going to be really led, isn't it, by what you see in front of you? Because the patient that's really obtunded, if we can get them out quickly, we're not going to want to stall by sorting out a sedation and bringing in extra risks if we can get away with it. However, if they're very awake and distressed and it's making it even more difficult, then I guess that's warranting some sedation. So I guess what I'm going to ask for, James, is a tiny bit of a lead into which way we're going here.
Okay, no problem. So listen, the vehicle's now upright. So you get the monitor on top of the vehicle, you run the leads through the open door, and you can now get some observations from the lady. So her respiratory rate is 28. Her heart rate is 130. Blood pressure is 90/60. And you've got her on a reservoir oxygen mask, and her saturations are 94%. And whilst you're doing this, the fire brigade have managed to at least take the steering wheel off. So you've managed to assess her, and she has got one fractured femur. You are still concerned about the pelvis, and she's got some pretty significant bruising on her chest wall.
Okay, and she's able to have a conversation with me?
She is. She's really distressed, and she's in a lot of pain, but you can have a conversation with her.
So I think genuinely a very quick conversation with her to say, you look like really badly injured. We're here to help. We need to get you out of here, and then we can do some stuff to really get on top of the situation and get you the help that you need. Two ways of doing that. We get you out like this, and that's going to be really quick, or we can pop an IV line in, give you some medication, acts as a strong analgesic, and you probably won't remember all of what's going on. That's going to slow things down a tiny bit. A very quick conversation, and we will see where we're up to. I guess anticipating that there may not be a coherent answer from the patient, in which case I guess you're going to reflect it back onto me again.
Well, no, so you do manage to have a bit of a conversation. She is really distressed, but she just wants you to knock her out. She's totally done with this situation. And so for what it's worth, you get consent or assent for this procedure. So I guess my question to you is, she's still trapped at the minute. If you think this does require a sedation, then when are you going to do it? Are you going to do it now while she's still trapped, or are you going to use it as the procedure being the extrication?
I'll be very happy to flick this on to Rob in a second, and he can take the even harder questions. But I think
they're all pretty tough.
The point is that I don't think require is, and I'm splitting hairs here, don't think require is the right answer. I think there's probably enough benefit warranted in sedating her, and that I think the risks are outweighed. And I think, in this patient that's in a really horrible situation, obviously, these huge concerns about hemodynamic compromise, or certainly that might reveal itself in a minute, even more so, and in a trapped patient, then, starting to give ketamine as soon as possible, if that's going to be the plan, is going to be the right thing to do in my mind. But being really careful about the amount that I'm going to give.
That's interesting. I mean, what do you think, Rob? Because, I guess the other school of thought would be that the longer you administer ketamine for, the greater the chances are for maybe some worse emergence phenomena beyond that. So, would you be more reluctant to be giving ketamine? And also, she's massively hemodynamically compromised already. I mean, do you want to start trickling in ketamine, or are you thinking maybe just some standard analgesia for now and then fall back onto your ketamine later on?
Well, hold on, I thought your fire crew were a bit more ready than this.
Get back, you've had your go, Simon, you've had your go. No, so I think it's an interesting case, and there's a couple of things. So, I mean, the patient is clearly unwell. However, with a blood pressure of 90, there might be an element of time that we could spend just to optimise everything that we can optimise in this person prior to doing anything. So I think that's the first consideration. Second thing is, I mean, it comes down to really how trapped this person is. So are they properly trapped, as in we've got an estimated extrication time of 10, 20, 30 minutes, or are they, as in, is it going to be a case of, cutting one post out and then they're free? And I think the reason that's important in this case for me is that I don't think that I would want to give ketamine if they were going to be in that car for a long period of time. And I think it's simple sort of opiate analgesia that you are very familiar with, you could potentially reverse if you needed to, and all of the caveats that come with that. If it's a prolonged extrication would be probably where I'd pitch it. But that being said, I think the point at which you would want to do the procedural sedation, I think, would be at the point of extrication, because this is going to be hugely painful for this patient. Now, if you are in a position to immediately extricate them and they don't have IV access in and they don't have the monitoring available, I think there is also a school of thought that actually we can just say, look, we're going to just get you out, we're going to get you set up, and the next thing that happens to you will be, you will be getting something that means you don't remember it. So I think it depends on the specifics of the situation, but I don't think that getting them out, if you can get them out immediately, that's not a bad idea in my mind, and I wouldn't want to prolong it for things like difficult IV access, etc., etc. I think that if the patient is ready to come out and has that in, then I think some ketamine would be my agent of choice to get them out so that you can fully assess them. But I think if they were distinctly trapped within a very mangled vehicle that you realistically weren't going to get them out for 10, 15, 20 minutes, I think opiates would be where I'd personally go up until the point of having that casualty free.
Great. Well, I think at least we're all in agreement. I believe that actually the procedure here is the extrication. That's when we're going to start giving the sedation. I think it's going to be a pretty unusual situation that we're going to sedate a patient who is still trapped. I can envisage times when you might, but it's going to be very, very unusual. And I think you mentioned, Rob, a couple of really interesting things that relate back to other considerations we might have around this situation. And for me, that's team and equipment. So you definitely want to be having real good chats with your fire brigade colleagues and liaising with them as to how quick you want them out and how long they will take to get the patient out. But also you want to be thinking about setting up your equipment for when the patient does come out, because if you're going to sedate this patient for the extrication, you don't want to be the hero proceduralist, does the sedation, whips them out the car, and then you arrive into a field of mud and there's nothing there, awaiting the patient. So definitely some extra things to be thinking about. So another question I'll flip back to Simon. A question for you, Simon. So this patient is really agitated. She's really distressed by this situation. This for me is the kind of patient that you might think, maybe I'll give them a bit of midazolam just before I sedate them with ketamine. Is that going to be a good idea here? What are you thinking?
So I think we'll get 10 different answers from 10 different people, won't we? And you can judge yourself where my answer comes.
I'm asking you, Simon. What do you say?
All right.
He's going all political. Come on. What are you going to do?
I like to keep it simple. So I don't think I would be giving midazolam to this patient before sedating them. We're already, having a wrestle in our minds about whether or not we are going to sedate them or just get them out quickly. So no, I'm going to be using ketamine for that extrication. And then if we run into difficulty of emergence, then I'll chase that up with some midazolam if we've reached a point of, relative physiological stability.
Yeah, I totally agree. I mean, if this was any other situation, then this patient would be getting midazolam from me anyway, because, that's the sort of patient that you want to calm down before you give them the ketamine sedation. But I think in this situation, you're just going to have to do your best to just coach her through the situation, try and talk her down, try and give her a nice entry into the sedation just through verbal reassurance other than a pharmacological agent. I totally agree.
Go on then, James. You haven't committed to a dose.
No, you're right. I haven't been asked. But my dose for this patient, it's going to be similar to that VT patient, isn't it? I'm pretty nervous about their presenting situation, but also, like Rob said, what might unmask sort of further down the line. And again, we alluded to the fact that ketamine is normally a very hemodynamically stable drug. But actually in these patients in extremis who are already kind of maximally catecholamíned up, they haven't got much more to give. And so we hit them with ketamine and you can end up making things worse. So I think, let's say she's 80 kilogram lady. So your 0.5 milligram per kilogram dose would be 40. So I think I would go in at half that again. I would go in at 20, make an assessment, see how it was. And if there was no effect at all, then I would give another 20. But if I was seeing signs that she was starting to slip into a dissociative state, I'd follow that up with another 10 and then another 10 if necessary. I think that's how I would go. Anyone do anything different?
Not for me. I think that's a really sensible approach. Yeah, I totally agree. I think reduced dosing, careful administration, and being cautious is the way to go in that.
Yeah, and boringly not from me either. What I hope these cases have done is to sort of illustrate the fact that we need to really weigh up the risks and the benefits of performing sedation in the context of procedural sedation. And what we've done in these different cases is consider really strongly different approaches other than sedation. And then when we've committed to sedation, we've then thought about the risks and the benefits, we've thought about the environment, we've thought about the patient in front of us, and we've thought about really tailoring it to that patient. We've then altered our dose of our agent, which we've picked for a specific reason, and then we've been really looking out for the complications that we might expect with that strategy and that patient in front of us. So there won't always be an agreement about the right way to proceed with a patient, but as long as you've considered all the relevant information and then tailored it in the best way possible and considered safety as a paramount, then that is a good way to approach procedural sedation with our patients.